And so, as I said, Trauma Grand Rounds, we have a great topic tonight, and we've got some excellent speakers on the panel. And so I'd like to hand over to Dr. Kate Martin, who's going to chair this session for us and introduce the speakers and the topic. Thanks, Kate.
Thanks very much, Jeremy. So welcome everyone to the second ANZUS Trauma Grand Round. Tonight it gives me great pleasure to welcome a long-term colleague of mine, Mr. Charles Pilgrim. Charles and I have spent many a hour over some nasty livers in the past. Charles is going to talk as to complex liver trauma and hepatic injury, and with that focus really on the surgical decision-making and operative technique. Before I introduce the rest of the panel, I do want to, at the outset, acknowledge the support of the of RACS, in particular Catherine Walsh in the Victorian office. Without their help, this really wouldn't get off the ground so smoothly. Charles is going to present the keynote address up until just before 7 p.m, and then he'll be joined by our very experienced panel this evening. Those of you that will be familiar with Professor Darryl Wall. Darryl Wall is a HPB and transplant surgeon and trauma surgeon based in Brisbane, has taught most of us on DSTC at some stage, and have certainly had the pleasure of not only being taught by him and examined by him in the Part 2 exam, but also then teaching with him. We're also joined by Dr. David Lockwood, who is the Director of Trauma at the Princess Alexandra and also a HPB surgeon, again based up in Brisbane. And Mr. Adam Bartlett is going to join us from Auckland City, a HPB surgeon from across the ditch, and bring his perspective to this the management of severe hepatic trauma. What I would certainly encourage our audience to do, and this worked really well when we had our first Trauma Grand Round, is during Charles's presentation, if any questions or queries or comments come to mind, please put them into the chat, and that way we can group them into themes, and we'll make sure we answer as many of them as possible during the 30 minutes of panel discussion at the end. So send through your questions, but at this stage, I am going to hand over to Charles. Catherine will help him share his screen to start his presentation on complex hepatic injuries, surgical decision-making and operative technique. Thanks, Charles.
Thanks, Kate. Thank you for the invitation to speak. I'll try and get the technology to work. Hopefully you're all seeing what I want you to be seeing. So I'm a HPV and trauma surgeon. I'm at the Alfred and I'm in the military. And tonight I'm going to talk about a few things, primarily the liver injuries that we see in Victoria and more broadly Australia. And then we're going to discuss what the liver does, and it bleeds and it leaks bile is the short answer in terms of trauma. In bleeding, we'll discuss the approach to the bleeding liver, touch on the AAST update from 2 years ago, and then the nice flow chart from the World Society of Emergency Surgery published this year, which I'll just spend 2 slides on. And then we'll talk about some cases, real world management of cases that have come through the Alfred in the last few years. Then we'll move on to bile leak, and I'll present an algorithm which we're working on to manage bile leaks, and then again, just 1 or 2 cases of that in the real world. So what are the injuries which we see in liver trauma? Well, at the Alfred over the last 11 years or so, we've got a cohort of 874 patients, which averages out about 1 or 2 per week. Not surprisingly, about 90% of them are considered major trauma, which is partly definitional. If you injure your liver, it's a major trauma. But it is also a realistic thing. If you've suffered a trauma that injures your liver, it's a major trauma. Concomitant with that, the median ISS for these patients is 22 compared to 9 for all of the trauma admissions to the Alfred. 3/4 of the liver trauma patients have a severe score of an ISS over 15. And not surprisingly, in Australia, 90% of the injuries are blunt. In the time frame there was 83 penetrating injuries, only 14 of which were firearm related. Interestingly, the number of horse injuries was 42 in that same time period. So you're 3 times more likely to have your liver injured by a horse than a firearm in Australia, which I think is really great, to be honest. The nature of the blunt injuries, about 2/3 of them are a motor vehicle driver, passenger or motorbike. And then when we include the other road users, cyclists and pedestrians, it counts for more than 3/4 of the injuries occurring on the road. 10% or 11% falls, and then, as I say, horse injuries, assault, and a smattering of others. It's a disease of males primarily, and younger males, as we all know, is true for trauma in general. And the mortality for liver injury is 4% at the Alfred, which is 36 patients over that time frame, which is in stark contrast to the mortality reported up to 80% in the 1980s. This seminal paper from the Annals of Surgery in 2000 demonstrated the dramatic changes in mortality associated with primarily a movement to non-operative management, but really the world standard is now 4 to 27% mortality, primarily because of four things. And firstly, the non-operative management, if they're stable. So if the liver injury is stable, if the patient is stable, liver injury doesn't really matter, and we leave them alone. If we do have to operate on them, packing over primary resection is the ground shift, which has improved mortality. Certainly, embolization has revolutionised our management, and probably most importantly, which I guess we begrudgingly say as surgeons, is probably the biggest change in saving patients is the improvement in the normalisation of physiology in the ICU. It's not so much about surgical technique, it's about ICU management and not operating on people who are bleeding and have no measure of stopping. But the mortality is 4% still, and if we look at the patients that died at the Alfred, a quarter of them, or 28%, were from unsurvivable head injuries. There were 19% of the deaths from hemorrhage, which equates to 7 patients over 11 years. But these patients just could not we could not stop the exsanguination. And it was multi-factor. It was bleeding from their lungs, bleeding from their liver, bleeding from their pelvis, and it's just too much. The 14% died from their comorbidities, which they came in with. Not much we can do about that. 14% died of complications following treatment, which isn't bad. Again, that's 6 patients. And then there was a few that the coders couldn't really work out why they died. It was a combination of their comorbidities, the complications, the multi-organ failure from the SIRS insult and so on. But it shows that really there's not that many people bleeding to death anymore from their liver injuries, which again is in stark contrast to what was happening in the 80s. Some other interesting data: more patients at the Alfred in this cohort had a negative fast scan with the liver injury than had a positive one, despite the fact that one of the views is, of the liver. Very few didn't have a fast scan, or only 45 patients didn't have a fast scan. So ubiquitous fast scan, but more commonly negative than positive, if anything. Which is interesting because I suspect there's an overcalling of a positive fast scan too. So I've seen plenty of positive fast that have a CT scan shows no injury in the abdominal cavity. So nevertheless, interesting data point. Some other interesting data points: 20% of patients had activation of the MTP, massive transfusion protocol, and only 67% required ICU admission. And I say that because we've said that 75% of them were an ISS over 15. So interesting that not all of them went to ICU. The length of stay, median 9 days for liver traumas, with some outliers up to 200 days. Most patients went home. 46% went home. 39% went to rehab. Again, reflecting that they're young males. A few falls off ladders went to nursing homes and so on. But generally, people go home from this injury. So what interventions were required? Well, slightly different time period from July of 2010 till the end of last year. And 639 blunt injuries. All the penetrating injuries had surgery, but of the blunt injuries, 141 underwent trauma laparotomy, which is only 22% of those patients who had liver injury. And of those that had surgery, most of the time it was packing alone. 2/3 of patients who had surgery just had packing. 23% had some sort of repair or debridement coded, which probably means it was mostly just packed and maybe a little bit of, dead liver was stapled off or something of no great significance. Only 17 formal or significant resections. There's only 17 resections over those 10 years. Slightly different time period a few years earlier, but in a similar 10-year period, 31 patients underwent embolization. So more patients need embolization than need resection. And when you combine those two, although they're not the same time periods, we can say that roughly 70% of cases don't require any intervention of these severe liver traumas. which really speaks to how different our management is non-operatively now. So those head embolisation, this was presented by one of our registrars a few years ago at the IHPBA, these 31 patients who had embolisation. That reflects about 8.6% of the patients with a major liver injury, that's with an ASD of over 3. None of them died, and not surprisingly, most of it was a blunt mechanism, and most of it was the right side of the liver. Rarely the left lateral section, sometimes segment 4, but mostly the right side of the liver. The denominator is over 31 because many patients had more than one side of embolisation. So really life-saving and very neat intervention. Rather than digging into the liver to find the bleeding vessel, you just embolise it. It's revolutionary. So the topic is decision-making. So, the questions are who goes to theatre, who goes to IR, who gets scanned, and then what do you do? And the last question is, when do they go back to theatre? It's in some ways easy, when do they go to theatre, or who goes to theatre straight away if they need it. But the question of when you take them back, and my sort of line for that is, the expression sooner or later. Well, it's later rather than sooner. You don't rush these patients back to theatre because you need to normalise their physiology and have the clotting do its work for you rather than try and deal with a mashed liver. So who goes to theatre is relatively easy. If you're unstable when you come in with a positive fast, you go to theatre. And you don't know they have a liver injury until you open them up. They have a positive fast and they're unstable. That's the end of it. You don't scan them, you take them to theatre. Who goes to IR? Well, really, that sort of comes after who gets scanned. So who gets scanned is those who aren't sufficiently unstable that they need to go straight to theatre. They can have a positive fast, but if they are deemed hemodynamically sufficiently stable to scan, then you scan them. And then, well, if they have an arterial blush or a pseudoaneurysm, we would routinely then take them to the interventional radiology suite. And barring that, in the absence of a blush, if they're stable, don't really matter what their liver looks like. If it's smashed to pieces, but they're stable and there's no active bleed, just leave them alone. Which is, the classic medical student thing, medical student training, is you treat the patient, not the scan. When do they go back? As I say, a harder question sometimes, particularly when you've packed someone and it's a rocky first few hours, the first 4 to 6 to 12 hours, even 24 hours, you're kind of like, well, their pH is still 7.0 and their temperature is still 34 and they're still losing, they're still getting lots of transfusion. Do you take them back? Is there anything more you can do? And really my message is take them back later rather than sooner, because once you've packed them, you've done what needs to be done for the majority of patients, and you just have to be patient, allow the packing to do its job and physiology be restored. So now a bit on the technique of what we do for bleeding livers. So the basics, well, if you have a trauma patient who's bleeding from the liver, you want them to look like this. You want the trauma T. The midline laparotomy is a standard opening point. You don't know what's going on. Find out their liver's bleeding in a significant way. Don't hesitate to do the trauma T. You want the patient to look like this when you're operating on for a liver trauma. The basic mantra is pack, Pringle and angio, and that's really it for the majority of cases. You need lots of these to pack. If you're not winning, then a Pringle. And for elective liver surgery, I use the Rommel tourniquet, but for a liver trauma, the soft bowel clamp is easily available on every major set. I always check it on my finger before I place it across the porta hepatis in case she's accidentally given you a crushing clamp. You probably don't want to put a crushing clamp on the porta hepatis, but if it's a soft bowel clamp that you can crush in your finger and you're happy, then put it across the porta hepatis. It takes seconds, and that applies to Pringle. And then you can decide where to from there. If the Pringle stops the bleeding, you know that it's an arterial bleed, and if you have an angio suite or if you have a hybrid theatre, that's the next step. If you don't, then you need to control it directly under Pringle occlusion. So you've got the Pringle on, stops the bleeding. If you don't have an angio suite, then you do need to dig into the cleft and find and control that bleeding, which if it's primarily hepatic arterial or portal venous, the Pringle should give you sufficient access to and visibility to control that, unless there's back bleeding from major hepatic venous injuries. Just a side note that you can consider an emergency hepatectomy, but I am not a fan of this. I think it's dangerous and associated with the mortality of the 80s, really. But the concept, and if it's in extremis, you don't have angio, you can't control it. Every time you open the liver, it pours with blood and you don't want to do anything else, then you can do a glissonial approach and make a hepatotomy in segments 4 and 5 and staple across the glissonium pedicle, effectively blind, and you can do it rapidly. The risk with that is a patient like this, and this isn't a trauma patient, but it's relevant because of the anatomy. You can see that left portal vein here is really quite a dangerous one if you're going to just blindly put a stapler across. I'll try and move the picture of myself and everybody else. If you look here, if you just blindly staple off here, which is where you would basically do a blind right hepatectomy, the portal vein is not coming off here. It's not coming off there where you normally see it. Hopefully you can see my cursor. It normally comes off here somewhere. This really arches back, and you don't know that because you've done an emergency operation. Dangerous, right? So I'm not a huge fan of emergency hepatotomy. We don't do it very often, like almost never. So if you are having ongoing difficulties, I said before, you want the patient to look like this. Well, if there are ongoing difficulties, you want the surgeon to look like this. This is Darryl Wall. For those of you who don't know, who probably isn't anybody on this teleconference. But if you put the Pringle on and you still can't control the bleeding, then the Darryl Wall technique of caval control is really life-saving. So what is that? It's suprahepatic control of the IVC in the abdomen. It is required when the Pringle slows the bleeding, but not enough to allow control and repair. To put it another way, if you don't have adequate control when you're exploring a liver laceration under Pringle, you also require infrahepatic control of the cave, which isn't as complex as suprahepatic control. You can do that at the foramen of Winslow if you need to. You can cockerize your duodenum and get more access to the cava below the liver. Do remember there's lumbar veins. So if you're trying to get around the cava and you can't do it, and you're thinking, oh, it's just a big blue tube, there's some big veins that go into the back of it, which you don't want to get into. The technique itself, you divide the falciform and the triangular ligaments and retract the liver to the patient's right and open the lesser omentum to find the right crus in the IVC. Here's a picture of it. Don't do it laparoscopically. Clearly, this is a photo from a fundoplication, but it shows nicely the anatomy. So this is the caudate and the IVC and the crus. And what you've done is reflected this. So the whole left lateral section is reflected back away this way. This caudate's quite amenable to it. Often you don't see much of the cava, but in this picture it's quite a good one, which is why it shows it. You dissect along here. And really the critical part of Darryl's technique is to put a gauze swab here behind the cava. And it seems like a simple trick, but it is an excellent trick. You then replace the liver, roll it the other way to the patient's left, and dissect behind the IVC from the patient's right. And the beauty of having the swab there is you're digging behind the cava and you'll come across a swab. And instead of digging blindly into no man's land behind the cava, you dig onto a swab, you're like, I know I'm sweet, and you put this control the cava above the liver, and you've got excellent control. So really an excellent technique, and Darryl should be given all of the credit he deserves for describing it. If you're having a really bad day and you can't even do the Darryl Wall technique because every time you lower the liver, you just get a rush of blood from the cava, then you might have to do this and open the sternum and control the IVC as it enters the base of the right atrium. This is a picture from a cardiology paper, but it nicely reminds us that the IVC has the least fibrous pericardial reflection among great vessels, but there is a pericardial reflection nevertheless back here. So the cava sort of invaginates embryologically into the pericardial sac. And so to get around the cava underneath the heart, you have to divide that bridge of pericardium. And if you do that, you've got this huge, big tamponading sheet of muscle that's keeping the blood out of your face, and you can get around that and control the cava above if you can't do it in the abdomen. And that's used occasionally, very occasionally, but it is life-saving. Has to be a really bad day for that. Just one note on some adjuncts for penetrating injury. Flow seal is clearly a great technique to just blast down a bleeding cavity, more or less anywhere. And this tube here, all of you who've done the DSTC, which again is I'm sure all of you will know about, cutting a finger off a glove and tying it up and blah blah blah. This is on the shelf in the hospital. It's a Seng, Stark and Blakemore tube or Minnesota tube. This one's a Minnesota tube, but the same thing for bleeding esophageal varices. It's got two balloons. which you don't have to be cutting gloves up for. You can just place that down a track and blow it up. I really sort of got the idea from that when I spent some time with in Baltimore in the shock trauma centre there, and had a patient that got shot in the face a few times, and all of the holes that were just exsanguinating blood, they just stuck Foley catheters down them all and blew them up. So you've got a balloon tamponade very easily available, and this is a nice one to use theoretically. I've not used it, but a theoretical one that I've thought of to use in a case where you need to tamponade something. So the actual technique, as I say, pack Pringle angio, you pack them. If the bleeding stops, great. Take them back later rather than sooner. If packing is insufficient, put the Pringle on. If there's ongoing bleeding, then you've got major hepatic venous bleeding, and phone a friend. You know, the reality of this is it's a very difficult problem to manage. If the bleeding ceases, then you've got arterial or major portal venous injury, which you need to take them to angio. The devascularized liver is the only time that I think a staple hepatectomy is a good approach in a damage control situation. If you've got a hanging bit of liver that's just hanging on by a thread, then you can staple that off. I don't have a problem with that. But then it's angio. It's expeditious angio. It's not 3 hours later. If you've got an angio suite, hybrid suite, then you're golden. You just put the Pringle on and wait for them to arrive. But even if you don't, you can, with packing, get the patient back down to the CT scanner and scan their liver only. Now is not the time to be doing reformats of the scaphoid bone. Now's the time to be doing a rapid CT abdo. Are they bleeding to death from the liver, which is what you think they are? And if that's proven and there's active blush, then back to the angio suite expeditiously. And, it's going to muck around. You're going to take half an hour to do that, but it's time well spent rather than, do something more heroic and potentially dangerous. So pack Pringle angio is how to control virtually all bleeding. Embolization, as I said, has revolutionised the management, but until recently hasn't been incorporated into the AAST guidelines. And we wrote this paper based off the data of the embolization cases that we had and submitted to the Journal of Trauma and Acute Care Surgery in 2017, and they roundly rejected it. We wrote hepatic artery embolization is a time to update the AAST. And I mean, I've had plenty of papers rejected, but this one was shredded by the reviewers. Like, they just said it was the worst paper they've ever read, which was really interesting because 6 months later, there was a paper that was, titled Organ Injury Scaling 2018 Update for the Liver. And interestingly, the new imaging criteria included presence of a liver vascular injury or active bleeding, and upscaling to a grade 3, regardless of the other parenchymal injury, or a grade 4 if there's free bleeding into the peritoneum. So that has been incorporated into the AAST now. I'm not bitter at all that our paper got shredded and we were told we were idiots, but I'm pleased that the AAST has incorporated that. I think it really is important. Basically, there's nothing else which they change, to be perfectly honest. Like, the rest of this is exactly the same as it was in the previous version, in terms of depth of laceration, extent, and hematoma and disruption of lobes and so on. But they have included now the presence of a vascular injury on CT, which is, it's taken 20 years to get to this point. But nevertheless, it is now part of the injury organ scale, which I think it should be. So that's a good thing. A relatively new guideline, or a guideline published just this year, from the World Society of Emergency Surgery. I think it's quite nice. It's lots of words, and I'll talk you through it. You can probably cut out half these boxes and just say it much more simply by saying packing an angio, but nevertheless, a liver trauma who is unstable or a transient responder with a positive fast needs surgery. So that's simple, right? Unstable, positive fast, surgery. No argument really. Massive transfusion protocol activated. Stable, CT scan. It doesn't really matter if it's minor, moderate, or severe. If there's a blush, they go to angio. So, pretty simple. Unstable, positive fast, theatre. Stable, CT scan, blush, angio. If there is no angio, if there's no aneurysm or blush, then just observe them, regardless of whether it's minor, moderate, or severe. They may need surgery for other reasons, and so on. And all of this is just sort of filling in the boxes. But basically, as I said, unstable, positive fast, surgery, stable, CT scan, angio if necessary. For the severe traumas, you've taken them to theatre. If it's minor bleeding, then check for the other bleeding source, because, you know, that's not the liver, but they're bleeding to death from something else, and deal with the liver in a simple way. You know, packing or argon beam is quite a nice way of controlling surface bleeding, topical agents and so on. If it's major bleeding, here is the mantra: pack, Pringle, angio. Right? So again, that's what you do: pack, Pringle, and angio. If you control it, great. It's the end of the story. That's all you do. Obviously, you make sure there isn't a major injury to something which needs repair or a ligation and so on. But basically, there isn't, because you've controlled the bleeding by definition. If it's uncontrolled bleeding, then that's where you need Daryl to be in the room with you, and hepatic isolation, liver mobilisation. Suprahepatic control, either transdiaphragmatic, transthoracic. You know, I think the sternotomy is the way to do it, because I think if you try and open the diaphragm, then you've lost that natural dam preventing the tidal wave of blood in your face. So I think a sternotomy is a preferred approach. But nevertheless, that's when you get into that liver mobilisation, hepatic isolation phase, which thankfully is rare. So a few cases of bleeding. This patient was a 30-year-old struck by a street sweeper, not a high-speed motor vehicle accident, street sweeper, but nevertheless, he was dragged for 50 to 100 metres, which was nice of the driver. Anyway, when he arrived, he was sufficiently stable to get a scan, despite the fact that he had a positive fast. He had a massive transfusion protocol activated, and his scan looked like this. So injury to the right lobe, some free blood, more injury to the left lobe. So quite a dramatic appearance. The left lobe and left lateral is really smashed, and the left portal veins running right through the middle of it. So that's kind of bad. You know, that's a nasty injury. So he did have a positive fast. He did have a lot of blood in his abdominal cavity, and he did go to theatre. He had the hepatic injury we knew about. He had a grade 5 splenic injury, which I neglected to show on that last scan because I was too busy watching the liver. He had a spleen out, which is quick and easy. And then his liver injury, the capsule was intact. So, you know, if we hadn't scanned him, you wouldn't have any idea that the inside of his liver was as bad as that. So we just put a few packs around it. You know, the capsule is the best pack. If the capsule hasn't breached, that'll contain it, you know, in a great way and perfectly anatomically. Yeah, also a little peritoneal reflection tear, but otherwise no other injury. So he had his abdomen left open, packs came out 2 days later, and eventually went home 2 weeks later. He did have a repeat scan because there was some concern about an arterioportal fistula, but the formal angiogram did not show that. So really very little to do. You know, terrible looking liver, but packed and spleen out, and that's all we had to do. So he's another patient, just recently managed by one of the new HPB surgeons at the Alfred, June BAM. This guy was 30 and found in an apartment block car park with halter conscious stays. Who knows what happened to him? There was a window that was open 4 stories above. Was he pushed? Did he jump? Something else happened? Don't know, but he wasn't in a good way. When the ambulance arrived, his blood pressure was 80/50, his SATs were 87, and his GCS was bad head injury level. He got to the Alfred, 16, 17 minutes later, and his blood pressure is now unrecordable. His SATs were even worse. His GCF was even worse. His pupils are fixed and dilated, and his temperature was 29 degrees. So, you know, pretty bad trauma, right? Not surprising, he had a positive fast. He was a transient responder. His blood pressure got up to 70 or 80 or 90 with the massive transfusion protocol. But then he dropped his bundle in terms of his lungs. SATs dropping into the 70s despite 100% O2. He had a bronch in ED, and he had a lot of blood in his bronchus, and some improvement after the clot was extracted, but it was suspected he had a pretty bad lung injury as well. But he was dying. His SATs were 80%, his blood pressure was 80 despite ongoing transfusion, so he went to theatre. His temperature when he was leaving ED was 31, so that's better than 29, but not much. His pH was 6.9. His lactate was 10, his base excess was -16, his clotting was sort of uninterpretable clotting when your temperature is 31 and pH is 6.9, but they were, you know, disordered too. You know, at laparotomy, he had blood in his abdominal cavity, and you know, it was watery blood. It wasn't clotting in any way, which is not surprising given those parameters. He was packed, but that also, or that almost killed him. It worsened his blood pressure, and his blood fell to sort of 40 or 50, and he was, about to arrest. So packs were taken out, and he had compression of his aorta, which seemed to ironically exacerbate the bleeding from the left liver. And you just couldn't do everything. The aortic control in the abdomen couldn't allow packing of the liver or Pringle to be put on effectively. So his anterolateral thoracotomy was performed, and his aorta was controlled in his chest. It was suspected that he had pretty bad bilateral liver injuries, and so he was packed and vaxxed, and with the plan of sending him to ICU by the scanner. So this is his scan. So I got a lot of packs in. Got a bit of a hematoma in here, more of a hematoma here, more liver injury sort of here and here and here, and actually sort of everywhere, right? So his liver was pretty mashed. Just a few static shots. There's that bit and that bit and that bit. So he kind of bleeding throughout his liver. Anyway, he went to ICU with the packs in and that injury. No active extravasation seen. He had 38 units of pack cells and lots of the rest. He had some escalation in his inotropes during the first 24 hours, the NORADs up to the 20s. There was a push from ICU to take his packs back to improve venous return, which just seemed like the most ludicrous thing I've heard for a while. So we resisted that, and the packs were taken out at 48 hours. And look, like I said at the start, it's a difficult decision to know whether you should take them back or not. But I really honestly believe if you'd taken that guy back still without his physiology restored, he would have bled torrentially again, and this time he might not be so lucky. So resisted the temptation to take him back and tinker, because that's what we would have been doing. So we left the packs in, took them out at 48 hours uneventfully. Packs out, closed him up. He went to ABI rehab 7 days post that injury, which, I think is a remarkable effort. I mean, that guy's as close to death, and his liver is smashed badly. Packed it, take him out, go home. So that's a great outcome, and really just reiterates how good packing is and how important restoration of physiology in ICU is, and how that saves patients' lives, and how we can kill them if we start doing crazy things. So getting more complex now. This patient was 17 and drove into a parked car under the influence of ice. He was a bit agitated at the scene and so on. His numbers are pretty good. The ambos said his blood pressure was 110, heart rate's 90. Mucked around for half an hour and still okay. Blood pressure 70, blood pressure 150 and heart rate 70. Got to the emergency department and, crashed, but not immediately. And so he was well enough when he first came in to get a scan. This is his scan. So it looks okay. Yeah, looks fine. Yeah, no issue. All good. And then, oh, no, there's some stuff up there. Oh, actually, there's a lot of stuff up there. Yeah, that's pretty bad, right? So he had, and this is the coronal images. So he had a pretty bad injury high up in his liver, and that is a tear in the vena cava, which you will rarely see on a CT scan because a patient will often not make it to the CT scan. But he had a hole in his cava. He was taken to surgery by Marty Smith, and his left and middle vein had been avulsed from his IVC. He was actually taken to theatre by the emergency trauma surgeon on for the night, who was not Marty. And every time they lowered the liver, they just got a rush of blood. So they just called Marty, which was very sensible of them. And he did exactly what I mentioned before, a sternotomy, controlled the cava in the chest, and then went back to the abdomen. And when he reflected the liver down, you can see a gaping hole in the cava where the left and middle vein had been attached. So that was oversewn. And because now the left liver isn't draining anywhere, a rapid stapled left lateral, not a formal left, just a left lateral, was performed, which is quick and easy, with the hope that segment 4 would drain across to the right, which it should. So he was damage controlled and sent back to ICU. He had a bileak, but that's not that big a deal. He went to rehab 29 days later. Again, it's just phenomenal outcome from my colleague to be able to manage this hole in the cava. And I always remember he'd also had a broken nose, and his girlfriend, who I think was a nice addict too, was sort of saying, what about his broken nose? What about his I'm like, Jesus Christ, this guy has almost died. I have his veins, a Volstrom, his vena cava. You know what, the nose, we'll get there. But, you know, really a dramatic save, and he did really very well. He did get some biliary sepsis when his stent was removed 4.5 months later, but nevertheless made a full recovery, which is very impressive. This is a patient of mine who had a gunshot wound. He was 38. The bullet came in below the left nipple and was found in the right flank. Again, stable enough when he came in, heart rate 120, blood pressure 110. His path was positive. We got this scan. So the entrance wound was up here somewhere, and the bullet path came through here amongst these vessels, which you may have heard of, through this and then out there. So what we found was the bullet had gone through and through the left lateral section, out the left momentum, missing the stomach and duodenum somehow. I think it went through the foramen of Winslow. I think it went between the portal vein and the vena cava, which is just a ridiculous thing to suggest. But I can't see how it got from A to B without going somewhere there, and it did not injure either of those veins. You know, the temporary or permanent cavity didn't injure them, which is remarkable. Went through the top of the kidney, missed the hilum of the kidney, and ended up in his back. When he first went to surgery, he just had a pact, and not surprisingly, had bile pouring out the drain a few days post-op. So that's when I was involved, and we took him back to theatre and just resected his left lateral section, which, you know, was relatively straightforward. I think these are major biliary injuries where the bullet and the penetrating injury has gone through some major proximal structures. You need to just resect it early, and I think that's appropriate. And he went home day 17. It's telling me my internet connection is unstable, so hopefully you can still hear me. I'm not just talking to myself, but if I am, I'm sure somebody will text me. Moving on to bile leak, as the other major area, the thing which the liver can do. Background, the incidence of traumatic bile leak is between 0.5% and 20% overall, somewhere between 3% and 7% following blunt trauma. There isn't any consensus on the optimal management for it. It is commonly reported that traumatic bile leaks frequently close on their own. You know, anywhere between 65% and 100% of reports in the literature say that, you know, did nothing, just drained it and it stopped, which is quite different from, you know, the elective setting. So there's our 700 patients from July until December of last year, and bile leak was seen in 4.9% of them, or 31 patients, 31 of the blunt injured patients. The initial management for these patients, well, 23 of them underwent embolisation, which is 3.5% of the cohort. 17 of them underwent liver resection. 143 of them underwent surgery for any reason, and the vast majority were managed conservatively. So the bile leaks were seen in 12 of the those who had surgery, who had immediate laparotomy for hemodynamic instability, with one of those who then subsequently had an embolisation, and was seen in 8 of them who had an embolisation to start with, of which one of them then needed surgery. And 11 of the bile leaks were seen in patients who had neither surgery nor embolisation. So to look at that in a bit more detail, the 12 bile leaks that were in those who had trauma laparotomy as their first intervention, 10 of them were free bile leaks and 2 of them were bilomas. And 4 of the 10 free bile leaks were in patients who had a liver resection. So you cut across a bit of devascularized avulsed liver, and, you know, it leaks bile much more commonly than an elective liver resection. We have carefully gone through the parenchyma. In terms of those that had a leak after an embolisation as their first procedure, they were fairly evenly split between free leak in the peritoneal cavity and a biloma. And again, those who had no specific treatment, fairly equally split between a free bile leak and a biloma. Some of them who had no specific treatment initially ultimately had surgery for delayed peritonitis, which diagnosed their bile leak, or had surgery for an infected liver parenchyma. Interestingly, males were more likely to have a bile leak, and younger patients are more likely to have a bile leak. And not surprisingly, the higher grade injuries were associated with a risk of a leak. To say that graphically, this is percent, it's not numbers, because there's hundreds of patients in the no bile leak and only a handful in the bile leak, but the higher grade injuries, higher rates of bile leak, as to be expected. So this is quite important slide. The looking at here at the bile leaks versus the no bile leaks for each of the treatment modalities. So 9 out of the 23 patients who had an embolisation had a bile leak. It had an odds ratio of 16 in terms of likelihood of developing a bile leak. And that's a rate of 39%. So 39% of the patients who had an embolisation had a bile leak. None of them who had a bile leak in the setting of embolisation resolved spontaneously. So if you have a bile leak and you've been embolised, it doesn't get better. 13 of the 143 who had surgery developed a bile leak, which is 9%. Similar odds ratio. You know, if you have surgery, you're more likely to have a bile leak, but only 9% of those who had surgery had a bile leak, as opposed to 39%. And equally, only 2% of those who were treated conservatively had a bile leak. So let's unpack that a bit more, because I think the association and interaction between embolisation and bile leak does require some discussion. So clearly, I think it's important for me to say, first up, without hesitation, embolisation is clearly life-saving, and we should not hesitate to proceed with an embolisation or think, oh, I might get a bile leak. Not even for a second. If they need an embolisation, it should be done immediately without hesitation. And also, very clearly, if you have trauma to the Glossonian sheath, which injures the bile duct and the artery, that is more severe than trauma that injures just the bile duct alone. So it is a higher mechanism or a higher force that disrupts the artery and the duct. There's no question about that. So that confounds the cause and effect discussion, but you know, it is an important point to say outright in the first instance. I'll also say that biliary injury in the absence of a vascular injury may heal spontaneously, and in fact in our series 42% of the biliary injuries without a vascular injury resolved. In fact, sorry, 42% of all patients resolved without any intervention. 0% of those who had an embolisation in the context of biliary injury resolved. So if you have a biliary injury and then you embolise it, you know, that hepatic arterial flow is then blocked. That's the whole point of embolisation. And the bile duct just doesn't recover. You know, this is quite well established in the transplantation literature. If you have hepatic artery thrombosis, that's when you get biliary complications. That's when you get strictures and leaks. Transplant literature. And I really think that this is probably the trauma equivalent of the Strasbourg vascular biliary injury that we talk about in bile duct injuries post-lap chole. You know, we all know a bile duct injury post-lap chole where you've clipped the bile duct and the hepatic artery, much worse than just an injury to the bile. This, you can extrapolate this to the liver trauma setting. If you have a biliary injury and on top of that a vascular injury which requires embolisation because the vascular injury is bleeding, then it's a much higher grade injury that doesn't resolve. Which has been we've found and reported elsewhere with a bile leak post-embolisation 43% versus 1.5% in conservative managed trauma published elsewhere, and that's virtually the same numbers as us, 39% and 1.5%. So if we look a bit more closely at our bile leaks, there were 31. 42% of them resolved with conservative management. One of them needed a drain, but basically resolved spontaneously. Most of them had a CT IVC that showed that the injury was not proximal. And 3 of them, interestingly, are actually failed ERCP. So we wanted to do an ERCP, but technically couldn't. One had a halo brace and the other 2 you just couldn't get to the ampulla. So, but ultimately they resolved without the ERCP. The remainder had an ERCP and a few of those needed a perc drain as well. But ERCP is not without complication, you know, in general, but particularly in trauma, it's not without complication. You know, one patient had pancreatitis, that's not a big deal. But intra-abdominal abscess is a big deal. One of these patients had a perc drain, 2 of them had formal surgical debridement, and one of them had a liver resection for their hepatic abscess following an ERCP. That's a rate of 22%. Now look, they're very small numbers. There's only 4 of them, but there are only 18 ERCPs, and that's when you start at 870 cases. So no one's going to see this if we don't, because no one's got a series that's, you know, over 1,000 in the Australian setting and certainly in blunt trauma. And so I hesitate to demonstrate statistical significance here because they are only small numbers. But the rate of liver abscess in the rest of the cohort of liver trauma is 0%. Nobody else had a liver abscess. The only people who had liver abscess were those who were instrumented and had an ERCP. and that was at a rate of 22%, which I think is alarmingly high. It didn't actually resolve the problem any faster either. The time to resolution was non-statistically significantly different. Part of the reason it was longer is because it took a few days before they got their ERCP. They didn't go home any sooner either. So now that I've finished alienating all the interventional radiologists by saying that embolization isn't perfect, I'm now going to alienate all the gastroenterologists by saying ERCP isn't perfect. But what are you going to do? But I will say, or I will make some points. The critical difference between ERCP following a lap chole or a liver resection is the fact that you've got a confused and battered liver, which you don't have in either of those other contexts. And, I put theoretically it may be colonised by following GI instrumentation. I don't really think that's theoretical. I mean, I think that's fairly fairly believable, even with a small cohort of 18 patients who had an ERCP and, 14 of them didn't have a liver abscess, but I might have to go back and see how badly confused their liver was, but 4 of them did have colonisation of that dead bit of liver. Now, again, as is embolization central and critical, there is no doubt that ERCP does remain central to management of bile leaks. It was attempted in 2/3 of our bile leaks and successful in most of those it was attempted in. So it is still a very important part of our treatment algorithm. But this rate of liver abscess, and not just, liver abscess needs a bit of antibiotics, like liver abscess requiring surgery or liver resection is a very clinically significant finding. And it has been reported before. At, again, a very similar level, 29% published almost 10 years ago by the group I say in their paper on ERCP trauma. But if you look at their data, they have patients have a liver abscess after ERCP. So really, an ERCP following liver trauma is not a knee-jerk reaction. It is a knee-jerk reaction. You have a bile leak from a lap chole to an ERCP. You have a bile leak after liver resection electively fine to an ERCP, but not for trauma. So this is the paper that Tom Scalia and his colleagues wrote from Baltimore saying, ERCP is effective in the management of bile leak after severe liver trauma. Like, yeah, great, it definitely is. But in that paper, they reported a 29% rate of bile leak. So I think this is a real thing, not just at our institution, but I think it's a real thing. And when you think about it, it does make sense. 10 years ago, 14 years ago, on laparoscopy for liver trauma. These are a few patients that we had in a series that initially conservatively managed, as more and more patients are, as we've said. Probably 70% are conservatively managed, but some of them will have increasing pain and distension and increasing fluid and so on, as you can see here, and need a laparoscopy and a washout. They haven't been operated, can laparoscope, wash out the blood and the bile, leave the drains. This patient resolved after 2 weeks, went home 15 days later, even after a high volume bile leak to start with. This patient, even more dramatic, managed conservatively to start with, but after 7 days, just grumbling on, unresolved sepsis, increasing distension, repeat CT scan, 6 litres of bile and blood in her abdominal cavity. Washed out laparoscopically, drains come out 3 weeks later. Nothing further required. No ERCPs, nothing else. Bile leak resolves with drainage. So based on what we've thought about in terms of this liver trauma or biloma containing liver or feed the peritoneal cavity. Now, if they have or bile, may not think out and drain them is probably the appropriate right thing to do. They may need an ERCP. Some of them won't, but it's a delayed ERCP. It's not one that you rush into. Sorry, I think I lost it.
Yeah, you're back, Charles. That's fine. Go for it. You're just talking about bile leak at the top of your flow chart.
Great. Let me just share my screen again. It's not letting me do that. Here it is. No. Yes. All right. So if you have a biloma, hang on. Whoops. My thing is frozen. That's not good. let me just exit my slideshow. And try and share it again. Right. Where was I? So if they have a biloma contained within the liver, then the next question you need to ask is, are they symptomatic? If they are not symptomatic, then don't do anything about it. Just observe them. A biloma will often resolve. Perhaps rescan them. Even that's arguable, but they don't need anything further. If they do have symptoms, then the next question we ask is, do they have a big devascularized area of liver? Because if they do, probably they are the ones that you should just bite the bullet and go in and resect, like that liver trauma from the gunshot wound that I discussed earlier. You know, devascularized parenchyma and a bile leg, that just go ahead and resect it. Again, Tom Scalea from Baltimore is increasingly doing this, and I think that that's echoed in our, experience, and is probably the right thing to do. But if they do not have devascularized parenchyma, then the next question to ask is, have they been embolized? If they have not been embolized and they do not have devascularized parenchyma, then just drain it. That's fine. This is symptomatic patients, just drain it. Again, delayed ERCP. They may need an ERCP, but don't rush to it. And if they have been embolized, then the next question is, do they have a major or proximal injury? And if they either have a major or proximal injury or they have been embolized, then the early ERCP is indicated, along with the percutaneous drain if it's a big collection. So the summary is, the early ERCP is only for patients who do not have a devascularized portion of liver and who have been embolized or do have a major proximal injury. The rest, wash them out, percutaneously drain them, and they'll often resolve. And this is not the same as management for bile leg following elective resection, as I've said. So to hammer the point, in case you haven't cottoned on, ERCP for bile leg and liver trauma is not a knee-jerk reaction. So we don't just rush to it. We do it when we need to, and 2/3 of patients will need it, but not as a knee-jerk, yeah, just get them to the ERCP. So in the last few minutes, I'll just present another case or two. This clever gentleman thought it would be funny to climb a power pole and then swing off the power lines. It electrocuted him and he fell 9 meters and burnt himself, a third of himself. The liver injury was initially conservatively managed, but on day, and this is the image of it, so his liver was injured just right through there, just split, basically. But nothing needed to be done. He was stable and well. His hemoglobin did drop and his pressors did start to go up day 3, so we thought we'd better scan him again. And that's his scan there on the repeat. And, much the same. Is there some blush contrast? Oh, is it probably a bit more than there might be? Is that a bit of contrast? Or is that a bit of contrast? Is that a bit of contrast? Maybe, yeah, maybe he's bleeding from his liver. So he was taken for embolization. At the time of embolization, there wasn't any active bleeding seen, but the interventionalists prophylactically coiled the areas that were visible in the cleft of the injured area. He was then taken to laparoscopy and washed out 1.5 litres of bile and blood and drained. His bile leg did not resolve, as I've preempted. Here are the embolization coils. Here's the pretty obvious bile leg on the CT-IVC 7 days later. So his bile leg didn't slow down at all, and he therefore, we said, yeah, he needs an ERCP. I think, and this was a historic case before we really introduced this algorithm. I think we wouldn't have waited 7 days now. With what we know about those who are embolized do not resolve their bile legs ever in our series. If he'd been embolized, he had a bile leg, fine, needs an ERCP. He does not have any devascularized parenchyma. He has been embolized. He fits perfectly into our algorithm of this guy needs an early ERCP. He stayed in for a few weeks, primarily because of his burns, but the ERCP did resolve the issue and it was not complicated by a liver abscess or anything of that nature, probably or partly, no doubt, because he didn't have a big dead bit of liver there. So the last case I've got, the topic was complex liver injury. So here's probably the most complex patient that we've managed in the last 10 years. This guy was 21, motorbike injury, GCS on arrival was 6, crossing too fast. He had a massive transfusion protocol activated, persistently hypotensive. He was a non-responder, so he went straight to theatre. He had a pretty obviously bad liver injury and what was said to be a non-expanding zone 1 and right zone 2 retroperitoneal hematoma, said to be non-expanding. He was stabilised sufficiently with the packing that he got out of the operating theatre and was intended to be sent to ICU by the CT scanner. But this is his CT. So he's got a bad liver injury. All of this is just dead liver back here. And then this is the most impressive extravasation of contrast I've ever seen. You know, I don't know how this is non-expansile hematoma. This is just blood pouring out from everywhere. So he, if I just take some standard shots, like that's not in any vessel. You know, I've looked up and down these scans. It's not in his cava. It's not in his portal vein. That's coming from his adrenal artery. His cava is here. So, you know, I accept the surgeon who was there at the original operation said non-expansile hematoma in the retroperitoneum. It started bleeding at some point, and importantly as well, this is just dead liver. Like all of this right lobe is dead. So, given the degree of hemoperineum, he went with the most senior. I'm not even joking. Like the most senior vascular surgeon at the Alfred, and also the most senior HV surgeon at the Alfred. And talk about the dream team. You know, if they can't stop bleeding, then no one's going to be able to. So those guys took him back and they repacked his liver. There was ongoing blood pouring out. And those two guys who have the utmost respect for just went, you know what, we're not going there. We are not going back there. And hence they just packed it and sent him to IR. And he had embolization of lots of vessels and adrenal arteries in segment 7, segment 8, and ultimately had 97 units of blood prior to entering ICU. But he did not bleed to death. Of course, he got a bile leak. The packs came out on day 3, so later rather than sooner. So he was left with them for 3 days. Taken out, not super completely dry, put back in, ultimately finally removed on day 5 and with an open abdomen. And by day 18, his vac change, he had, frankly, bilious output. And then the next day, he had 1.5 litres of bile come out from a pleural effusion. So, yep, diaphragm injury, not identified, no worries. That was attended to. And this is his CT-IVC, which showed bile just pouring into this dead bit of liver. Embolization coils, again, I just don't believe these things don't go together. You know, bile pouring into this dead bit of liver right at the back here. Now, arguably, with the benefit of hindsight, should we have taken him to theatre now and resected this dead lobe? Well, I can tell you that he took a while to recover. Ultimately, he went to rehab on day 48, pouring with bile from his drains, but at least he went to rehab. He came back 2 months after discharge, now 4 months post-injury, long-term surgical drains, pouring with bile, readmitted with an infected perihepatic collection. This is a ERCP and you know, just pouring out. He had the stent change and so on. So that was 2 months post-discharge, 4 months post-injury. In and out of outpatients constantly, on and off an antibiotics for infected collections constantly. 13 months post-injury, you know, still representing with fevers and abdominal pain. But ultimately, a year later, 13 months later, it had sort of matured into this just fluid and bile-filled cavity, which was drained. And after another week in hospital, it finally resolved. Most recent update, 2 years post-injury now, and no further issues. So, you know, but he was the hardest case we had on the wards for months. And we all kept sitting around the MDT and the unit meeting every week saying, anybody feel like taking his liver out now? You know, 6 months later, 7 months later. And we ultimately did not. And ultimately it did resolve, which is, you know, really, again, a great advertisement for conservative management. But I do think probably the opportunity to resect his dead liver was, you know, within that 2-week mark. You know, clearly not the first day, because he would have died if we'd opened up that retroperitoneum. But perhaps 10 days later, 14 days later, difficult hepatectomy, no doubt, but it may have spared him a year of bile leaks and infected collections and so on. It may have. It also may have killed him. So the retrospectoscope is always a dangerous instrument. But nevertheless, at the end of the day, he recovered. So that's about it. The summary then of what I've said is the liver bleeds. and the liver leaks bile. But often, neither problem needs anything much done about it. If you do need to operate for bleeding, the mantra is pack, Pringle, and angio, and that deals with almost all cases. I mean, we've had to, Marty's extravaganza and clamping the caver in the chest is the first and only time that's been done in the last 20 years at the Alfred. So, all these techniques are important to know, and you may use them once in your career or you may not, but pack, Pringle, and angio is the mantra and deals with mostly all the cases. If they're leaking bile, drain them if they're symptomatic, either laparoscopy if they haven't had surgery. If you do an operation for a liver trauma, leave it drained, and if bile comes out of it, then leave it. Or if it's a biloma and they're symptomatic, then drain in radiology. And be patient before committing them to an ERCP, unless they've had an embolisation. If they've been embolised, they need an early ERCP. If they've got a major and proximal injury, they need an ERCP. But otherwise, be patient. You don't need to rush. So maybe it's not that complex after all. That's all I have. Happy to have some discussion now.
Thank you very much, Charles. That was a very comprehensive rundown of liver trauma. I'll just wait until we bring up our panel and I'll introduce them all to you again. Excellent, thank you. We've got David Lockwood, Charles Pilgrim, and we have Daryl Wall on live. Can we see his face? We can. And is Adam Bartlett there? Somewhere. There's Adam. Excellent. 1, 2, 3, 4. Welcome, everyone. So thank you very much, Charles. That was great. Very, very comprehensive. I would like now to introduce our panel for discussion for the next 25 minutes or so. Adam Bartlett from Auckland, Daryl Wall, and David Lockwood. So welcome, everybody. Now, we do have a few questions that have come through. They were slow to begin with, but we've definitely got a few through now. So I might try to put these all into themes and maybe go back to something really, really basic. And the first question is describing how to pack the liver. And I might put this first to you, David Lockwood, if that's okay. Could you just go through for maybe the DSTC participant, for example, what have you found is the best way to pack a liver in that initial sort of part of your laparotomy?
Thanks, Kate. I better correct you on one minor point. I don't consider myself an HPB surgeon anymore. I was HPB trained, and it's given me a few skills that are quite routine for general surgeons, but that's not a mantle I can wear. But that in some ways probably makes me a little more representative of the people who actually have to deal with that. That's usually my role on these panels. Liver packing. First of all, I don't think there's as much consensus about that as we like to pretend. We would agree on the major things that you can do wrong, but it is a little bit of an art form. So we would all agree that the aim of packing is to restore the natural contour of the liver, that you're always trying to pack cracks together, particularly in blood trauma, the bear claw type injuries. I think the important principles, the things that you can do wrong apart from that are to do too much packing on top of the liver and just lift up the diaphragm. That doesn't give you very effective packing at all and just reduces your right lung volume. You'll see some pretty impressive examples of packing. The tempting thing is to just to pack very extensively anteriorly and laterally, which is the easy bit to get to. And if you do that too much, you will find that you're very directly compressing the caver against the vertebral column. And a lot of those patients will survive, but it probably does have some implications for causing abdominal compartment syndrome. In my view, and this is only a personal view, there is a role for mobilising the right side of the liver in those injuries to try to get some packing behind, if you've got a particular problem with the right lobe of the liver, to get packing behind the right lobe and in front of the right lobe, so you get direct AP compression of some of those injuries, but sometimes that just won't solve the problem either. Anything that's bleeding should have some pack on it to get some extrinsic pathway coagulation happening. We do use the flow seal and so on a little bit, but that's not the key. I think that sums up my additions to the very basic guidelines of restoring contour.
Just to add to that, is there any role for mesh, do you think, in packing? It's certainly described in splenopathy. I've not seen it, but I guess it's potentially something people would consider. Have any of our panel used mesh to aid in packing a liver?
I have not. I would call it sponges. I would use sponges as my mesh. So I prefer to others.
Yeah. Alrighty. Along the same lines then too is the role of getting access to the upper part. So there, again, it's a procedure not done very often, but when it is needed, it is heroic. So we might as well deal with it now and move it out of the way. And that is the stenotomy that was used in the case that you described, Charles. I guess maybe this is for you, Daryl. What's easier, an anterolateral thoracotomy or a stenotomy? We'll assume that there's no cardiothoracic surgeon in the room. Or is there another technique that maybe doesn't involve, is there another window into that area? Just unmute there, Daryl. Can't quite hear you there, Daryl. Can you hear me? Let you unmute.
He's not muted, but we're not getting his audio.
No, I've got you down as muted, Daryl. I've still got you coming up as muted. You've got a little red. That's better. Try that. Oh. No. We might try to get you fixed up in a tick. Try that again. Last go.
And while we're waiting, I might give a surgeon's answer to that if you like. I would, all of those skills require something that not all of us do. And if you're doing it for the very first time, you're just going to have to do whatever you've done before. In my view, so a left anterolateral thoracotomy will not give you great access to the cava at all. So that's not the answer there. It will obviously give you access to the descending aorta that Charles has used on that occasion. We all have. Median stenotomy is not a hard thing to learn, but you can't learn it on the first time that you want to use it. So if you can do it, I would say that's an easier thing to do after you've done it once or twice than the retrohepatic dissection that Charles was describing. That's not for absolute beginners, I would say.
Okay, Daryl's lost his little red microphone. Do you want to try again, Daryl? No, that's not working either. Daryl, what I might ask you to do is log off and log back on. We'll continue on. Just try logging off and on again. The next question then, I think too, is there's a few questions regarding the Pringle manoeuvre. So in the situation where you've packed, it's only partly controlled the bleeding, and then you've needed to put a Pringle manoeuvre on, and yes, that gives you good control. So you're not worried about retrohepatic bleeding at this stage. You do have an angio suite, but it's not a hybrid suite. What do you do about that Pringle? Do you leave the Pringle on? Do you leave the tummy open? Do you leave a clamp on? Do you leave a vascular loop around? What do you do in order to get that patient to angio, or do we simply to have more focused packing with the view that we'll get to angio in time? And I might ask Charles and then Adam to maybe comment on that, if that's okay.
Yeah, so the first thing you say is you can't do an angio with the Pringle on. Because you think about the anatomy of it, if you're trying to get into the hepatic artery and you have a big clamp across it, you can't angio them.
Correct.
So if you don't have an angio suite, you can do that if you have a hybrid suite, which we don't at the Alfred. You just sit there with the Pringle on. As soon as they arrive, just take the Pringle off. But you can't do that if you have to transport them somewhere else, because I don't think it's really feasible or realistic to try and transport a patient from an operating theatre to an angio suite with a clamp on, their porta hepatis. I think it's sensible and appropriate to have a sling around the porta hepatis so that you don't lose control of that, but I don't think you should have a clamp on. I think the reality is it's actually often hard to tell if there's really arterial bleeding or not, because there's always bleeding in a major liver trauma. You stuff it with packs, there's always a bit of blood that comes out. It's not like all of a sudden it's dry, because remember, these patients are going to be acidotic, coagulopathic, and hypothermic, so they're still going to be bleeding into the packs. And so you go, well, I think that's okay. They're packed as well as I can, send them to the CT scanner, and then you go, oh, right, there is an arterial injury. Right, send them to angio. So I don't think it's as cut and dried as it may seem. And I think that, it's quite appropriate to leave a vessel loop around so that if you do have to go back to theatre, you've got a vessel loop, you're going to go back anyway, you've got to take the packs out, leave a vessel loop around, pack them as well as you can, vac them, CT them, transfer them to angio. And like I say, the critical thing is that it doesn't take 3 hours, and it really, unfortunately, it's such a temptation that when they get in the CT scanner, somebody's like, oh, just quickly scan their brain. Oh, just quickly do the chest. Like, no, scan their abdomen. And if they're bleeding from their liver, they go to angio. They can come back to CT scan, but just their abdomen. Don't reformat the scaphoid. Like I said, you just need to get the slices of the liver to see if it's actively bleeding, and if it is, and they need to go back to angio. And you can do that within an hour, and that's reasonable. Packing will control. It won't stop arterial bleeding, but it will slow it, and you will have control. And it's not like you're doing nothing else in that hour. You're still pumping them full of blood, and you're activating the people to come in to do the angio and so on. So I don't think you leave the Pringle on. I think you just get them to angio.
Okay. Adam, just wondering if you've got anything to add to that, and then I've got a follow-up question for you also.
I totally agree with what Charles is saying. I think if you've got a Pringle on and you still haven't got control, then it's got to be coming back from venous. And then you've got to start talking to your anaesthetist, because more often than not, your anaesthetist is running high airway pressures back at you, or they're dumping volume into the patient. And you're never going to win, because that's your back pressure off the hepatic veins. And you've got to actually rational the amount of volume that they're getting back in from the other top end. And I guess one of the differences, which I think we sort of push for, is that we go straight to the angio. We don't CT. So we pack, we go to angio, and then we might go to CT if we don't get the answer off that. The reason being is because I guess it's a bit more of a delay. You want to see the arterial bleeder before the venous. So that'd be the only slight difference.
Thank you. Well, following on then from that, Adam, and it's another question for you. We've put the Pringle on. It's not made much difference. And every time you do a little bit of mobilisation, particularly of that right lobe, you get a bit of a gush from behind. So you think that at least part of the component of this injury is a retrohepatic or a caval injury. What can what are the principles what the surgeon and the anaesthetist should do while we're waiting for our HPB colleagues to come in as that second set of hands to help us?
So you can apply a suprahepatic clamp with a curved vascular clamp over the top. As long as you divide the falciform back to the hepatic veins, you can get a clamp over. And as Charles nicely described, the Darryl Wall's technique of putting a gauze onto the left, it's surprisingly easy to get around that cava at the top, because there is only one posterior branch on the from the retrohepatic cava. It's the right adrenal. That's it. So if you come down onto that right side of the cava, you can essentially go straight up to the diaphragm and find the gauze, because there is no other branches. Once you've got that right adrenal, and that goes back to the principle in transplantation where we used to do caval into position. That's how you could do it, because of the fact that there's no other branches there. So it's a really nice technique which Darryl has described. And you can sling, and I tend to use a sling around the top of the suprahepatic cava rather than a clamp.
Darryl, are you online there where we can hear you?
Can we try again, Kate?
Yes, go for it.
Would you
like
for
to add to the
giving,
conversation?
thank you for giving the speech. Thank you for giving me the opportunity to thank you and Jeremy for giving ANZEST a voice. This is a great meeting, and I want to thank particularly Dr. Pilgrim, Professor Pilgrim, for his wonderful presentation, particularly emphasizing that the surgeon does not have to operate for bleeding. In most instances, it's a bleeding disorder, which is managed by damage control strategies. I also commend his timing for reoperation. It is 48 hours, not the intensive care staff's advice. So thank you, Charles. Very good show. And regards the access to the hot area, the what amounts to Pandora's box, it is best to be conventional midline T a sternotomy, but a technique which I've used, but I didn't develop at all because it was brought to me by Richard Bryant from France, and that is to take the diaphragm down around the margins. So you've got a skirt, take it down and tuck the skirt around the liver. Charles is right that blood's coming from every direction, and having a diaphragm in the way is a problem. But if you arrange the diaphragm, you can make sure that the blood is pressured under the diaphragm for at least a time for you to get access to the suprahepatic cava. And it's particularly valuable if the suprahepatic cava is actually the site of the injury. So it's uncommon, but it's an extra tool in your kit.
Thank you very much, Daryl. Well, still sticking with embolization, there is a question here about management algorithms suggested for a blush that's seen on CT with a liver injury. Embolization, though, has failed, but the patient is hemodynamically not compromised. So you've not compromised, but there is an active blush there on CT, and embolization has been unsuccessful. Should those patients go to theatre? And I will open that up maybe to Charles.
Yeah, that's a tough one. I mean, thankfully, the IR guys are excellent at what they do. So the number of times they fail is very rare, which is, is great. In all of HPV surgery, we ask them to do lots of things for us, and they virtually can always embolize this or drain that or whatever else, which is it's just revolutionised, HPV surgery, and is so critical. But taking the example, if they have it for some reason, I think if the patient is stable, you don't take them to theatre. I mean, you're only going to make things worse. You're not going to be very comfortable that you're leaving obvious arterial bleeding, but that's sort of incongruent with the fact that they're stable. So I think that you treat the patient and not the scan necessarily. And sometimes the blush on the angio is subtle. I mean, one of those cases that I presented, the radiologist said, yeah, I think that's a blush. And so they did take him angio and there wasn't any bleeding. So I don't think it's all 100%, blush. You must deal with it, angiographically or surgically. If they're stable and the angio fails, I wouldn't be advocating taking them to surgery. Wouldn't be discharging them, but I wouldn't be taking them to surgery. I'd have a low threshold if they became unstable, probably to re-angio them. But if not, then I wouldn't. I certainly, if they're not unstable, I certainly wouldn't take them to theatre.
Thanks, Charles. The last question, I think, in regards to angiography is what to do when that's just not an option. So a big shout out to our Fijian colleagues who are online tonight. It looks like there's at least a few. One of the questions that's been posed is that what to do with the patient who has good control with a Pringle manoeuvre intraoperatively and angio is just not available, full stop. And again, Adam, I might ask you this from a point of view in the operating room, what can be done with regards to controlling whether it's the common hepatic or the right or left hepatic? The pictures are good in the textbook. How easy is that, do you think, in reality in the setting of trauma?
Yeah, it's not straightforward at all. And we actually had a case not that long ago from Gisborne, right down the east coast of New Zealand, a gunshot injury to the right side of the liver. And using hepatotomies, we managed to talk the guys through encircling the right and putting a Pringle tape around. So isolated Pringle to the right inflow, and the patient was sent up and did extremely well. But, again, it comes down to a very difficult situation where you're going to have to try and isolate either the left or the right inflow if you don't have assistance. If it means taking out the artery first, that would be the easiest thing to do. If you can't do that, then do a Gleasonian approach using a hepatotomy type technique, but it's not without risk and it's not straightforward.
Thank you. All right, moving along a bit, we've got a question here with regards to, so we're moving into that, that follow-up or that longer-term management period. Role for anatomical resection after damage control and packing. I think, Charles, you touched on it a bit. I'm just wondering, David, if you'd like to comment on this, just from your experience, where have you seen liver resection used, if at all, in the sort of after the initial damage control laparotomy?
Well, it probably isn't really the question for me, but I would say that people, if you're a hatter, everything looks like a nail. If you're used to resecting, people tend to resect, and the history of this is certainly much more in favour of resections and anatomical resections, and Darryl Wall and his colleague Russell Strong were at the forefront of that. I think things have changed. I think the number of people who really are better off with an anatomical resection at any stage is much less. And I've certainly got quite a few people through with focal necrosis or pressure necrosis from packing that without a resection, where I know that some people would have recommended one. And I've seen some people get resections where I really think they probably could have got through without it. So I still think it's possibly sometimes overused. However, as Charles says, you don't really know you can only use that in retrospect. So most people don't need it, as Charles already said.
Daryl, I'm just wondering if you've got anything to add to that.
I respect David's experience. He's stood astride then and now, and that period of resection was successful because we didn't have ROTEM, we didn't have the ability to achieve good quality coagulation, and so being radical was a means of quickly controlling a large surface area. Those patients still needed packing, so it wasn't miraculous. So today, though, because of the marvelous damage control resuscitation and superior attention to the coagulation strategies, we very rarely have to be radical. With a couple of sections, a couple of circumstances. I just met a friend the other day, Wayne Kelly, who said, I told you when to do a liver resection, Daryl. And he said, I was right. He was right. It was a patient who had devascularized liver. And initially, the hemostasis was saving his life. But then the hemostasis was killing him because there was very little perfused liver. And what liver he had was dead and was killing him. So he called up a surgeon to save the patient from necrosis, not hemorrhage. That was Wayne Kelly.
And I think that may partly, oh, sorry, Charles, you want to add something? Go for it.
Yeah, so just the formalness of a hepatectomy for trauma, you're sort of just completing the hanging bit of liver.
Yes.
The right hepatectomies that I've done for trauma are very few, but it's torn and you just kind of staple the bits off that are hanging. It's not appropriate. I think it's an important message. It's not appropriate to say, oh, I'm going to do a formal liver resection. I'm going to, dissect the porta hepatis and formally do it like you're doing a right hepatectomy for colorectal mets. It's not that operation. All the transfusion, the distortion, it's not what you think it's going to be to try and dig into the porta hepatis. You just staple off the bit that's hanging. And it's sort of a little bit not anatomical, but it's the safest and best thing to do. If you leave a bit of bruised liver on the cut surface, that's fine. Better than getting into serious trouble and trying to have a clean resection margin. It's not an elective case.
As a non-anesthesia surgeon, I'll say you'll know those cases when you see them. You won't be confused. The injury has mostly done it for you, as Charles says, and you'll know that you're just tying off stapling off the last little bit.
And look, we had a case exactly that last week here at the Royal Melbourne, and it was, you do know, as soon as you have a look at it, it's asking to be finished off. Let's move on to, we can never have a trauma talk without a question about Reboa. Role of Reboa for uncontrollable bleeding from the hepatic veins. Is there a role for balloon occlusion of the IVC? Thoughts? Who wants to tackle that one?
Kate, I believe there's a role, and I believe that Thomas Scalia has led in that area, and they are doing it now. And I know that Barvik attended Shock Trauma Centre and saw that very activity. It was very effective. So I'm putting a word in here for trauma surgeons of the 21st century to train in vascular interventions.
Excellent. Well, it was Barvik's question. I think I can put that out there. All right. Well, and this is something I've certainly worried about in the past, particularly in these patients. What's your experience with use for VTE prophylaxis? First of all, initially, when would you be comfortable commencing chemoprophylaxis? And what's the role with IVC filters, particularly if there has been a cable injury or the suggestion of a cable injury? Adam, I'm just wondering if you've had any experience with IVC filters. I'm not sure if you guys are using them much in Auckland.
We try and avoid them like the plague because the number that you can actually successfully get out in the long term is not high. Hey, we tend to use subcutaneous heparin BD dosing as soon as their thromboelastogram comes back to normal. We start more on heparin subcut, not Clexane.
Anybody else?
I support.
David, what do you guys do? Yep.
I support Adam. Fantastic.
Yep.
Just give an anecdote about an IVC that was stripped like a varicose vein when a vena cava filter was removed. So I would definitely not put a vena cava filter in if there's a vena cava injury. I think that's just asking for trouble. Interesting that patient was fine because it was just a retroperitoneal bleed and they did all right, but it's a horrific thought. And I certainly wouldn't, be testing that and doing it again. I wasn't my patient, I just heard about it. But definitely if there's a vena cava injury, do not put a vena cava filter in. That goes without saying.
And just in the last 5 minutes or so, there's a couple of other questions. One is experience with traumatic liver injury. The question is in newborns, so I'm assuming that is potentially from trauma during delivery, but in children in general, maybe. Maybe Daryl, you'd like to try to tackle that one. Anything in particular that's different in our approach? Any major differences in the principles of the approach that we use in adults?
Probably the most important thing is the remarkable teamwork necessary, where you have to have a pediatrician, a pediatric surgeon, an intensivist, a hematologist, all working intensely and closely. And to me, it's of course very emotional being an adult surgeon, but they are cool, and that cool shared effectively. And the overall picture that we develop with the team is that give the child, even a newborn child, every chance to survive by avoiding hypothermia, fluid overload, because they're very susceptible to wetness. And I think also importantly, from the point of view of survival, they have to have really good lungs. So they do need a pulmonologist as well.
Thank you. I'm going to finish up with a comment from Jolt, and I'm sure he won't mind me using his name. Jolt's also a member of our executive at ANZUS. So thank you very much. As a young kid on learning about trauma, he actually wrote his MD thesis back in 1995 on blunt liver abdominal trauma. It included embolization, packing, rare indications for resection, resuscitation with early blood, plasma, fast CT, ABG-driven resuscitation, early monitoring of coags. He's asked what's new in this topic. Sure, there are refinements, but what would you pinpoint or summarise as the major developments over the last 10 years or so? And I'll probably ask each of the panel members this. I think it's worthwhile. I'll start with you, Adam.
I'd have to say it's interventional radiology. It's the assistance of interventional radiology. And as Daryl's even pointed out, I can't emphasise how important it is to get those skills. And in HPB surgery, we're starting to get into it more ourselves.
David?
I agree with Adam. So that's not new to Zolt. It wasn't new then. But certainly that's been the biggest refinement. I would only point out that I think the biggest reason that we operate on such a tiny fraction of what we used to operate on is not interventional radiology, though. It's just the resuscitation approach and not poisoning people with crystalloid. And that has absolutely radically changed how many people need an operation. When Darryl Wall and Russell Strong were operating on those patients, they really didn't have a choice. It's not that they were making a decision that you wouldn't have to make now. They had to operate because that patient would not stop bleeding. And now our colleagues managed to not make them bleed in the first place so much more often.
Charles?
Yeah, look, I think the ICU is what's saving these patients more than anything that we do, and restoring their physiology and normalising the coagulopathy and everything else. As much as I hate to say it, I really do think that's the critical thing in what's saving all these lives. It's not us being heroic and clamping the vena cava. I mean, once in 20 years, it's not really going to make a difference, but a big difference is in normalising their physiology and resisting the temptation to take them back before that job is done. That job is much more important than our job.
And Daryl, I'm going to leave you with the last word then.
Oh, thank you. I really appreciate the questions because they force you to expose your prejudices. And my future, I believe, is to have not so much an operating theatre, but a venue where the intensive care team work and the theatre staff work and interventional radiologists. Of course, this is already established with Raptor, but I'm talking about having intensive care there. If not, at least when you're in the theatre, you can ring up the intensive care staff and you bring the intensive care staff into your theatre and you start the post-op care even before you've achieved the hemostasis.
Well, we've sadly run out of time. I'm just going to quickly put up a page for you. I would thank you very, very, very much to our panel. That was an excellent discussion this evening, and I think really expanded on what was a very, very good talk. For those of you who are not ANZUS members and who would like to learn more about what we're about, visit our website. All of the information's there. And you will also this evening get sent at the conclusion of this webinar a link to a very short survey, which is really important. We've only just started up these webinars, which will run every second month, the first Tuesday of the month, and it will be each of the even months. So the next Trauma Grand Round is on the 2nd of February, and it'll be Silvana Marasco who'll be talking, rather than focusing just on rib fixation, thoracic trauma emergencies, and again, with that focus on surgical decision-making and operative technique. So I hope you can join us for our next webinar early in 2021. I wish all of you a very safe and merry and happy festive season, and hopefully your respective on-calls and trauma services won't be too busy as people enjoy the summer break in our part of the world. So once again, thank you very, very much, everyone, and thank you to our panel, and thank you to our guest speaker. Good night.
Thanks, Charles.
Thanks.
Thanks,
Everyone.
Kate.
Thanks.
Thanks, Kate.